My name is Krishna Kumar, and this talk is on the much anticipated changes to the surgical curriculum. This was an invited lecture given at BAPIO, which is the British Association of Physicians of Indian Origin, and it was as part of their CESR preparation week. So, what is the current curriculum about? The main feature of the current curriculum is that it's competency based. So what does that mean? It means you have to fill up evidence of showing competencies, and often these involve filling in about 40 case-based discussions per year in some departments, to about 40 PBAs or procedure-based assessments. In addition, you have to complete MSFs, assessments of audits, multi-source feedbacks, etc. So the whole idea of all this was the building block model. In the sense, you train a surgeon or you train a person in a certain competency, enable him to achieve a grade 4 status in it, put all these competencies together and create a fully functioning unit. Now, the idea that the trainers had at that time was to put all the blocks together and create a super functioning surgeon, something similar to this. However, the final result was not always so flattering, and it often ended up like this. So, the trainers then went back to the drawing board, and the idea became to change from a consultant which is competency based to one which is outcomes based. So, what does all this mean? In the new curriculum, one feature is there is a lot of heavy jargon. You hear terms like outcomes based, GPRs, the generic professional responsibilities, CITs or the capabilities and training, and the dreaded multiple consultant report. But what does all this really mean? The driving force behind the new curriculum was that the knowledge and skills required for everyday practice is authentically reflected in the curriculum. And it was felt that the problem with the last curriculum was, or the previous curriculum, was there were often gaps, and the final cohort of trainees which came out were often found to be lacking in the day-to-day consultant skills which were required. Now, the new curriculum for the CESR candidate consists of 4 parts. Part 1 is a training and qualifications. 2 is knowledge, skills and experience. Most of you will not have any issue with part 1 and part 2, but it's part 3 which is the CIPs and part 4 which is the GPCs, which is what we will be focusing on in this lecture in detail. Now, CIPs or the capabilities in practice. There are essentially 5 CIPs, which is managing an outpatient clinic, managing your emergency on call, managing ward rounds and theaters, conducting an operating list, and participating in an MDT meeting. Now, in the next few slides, I will go into detail as to what is required in each and how you will be tick-boxed across. Now, the trainees or the candidates will be assessed against the daily tasks required of consultants in the working week. And this is why the CIPs are being introduced. So, let's go to the first one, which is the outpatient clinic summary. What will you be assessed against, or how will the CIPs be assessed in the clinic? Now, this is basically something which you all do in your day-to-day practice, but what they are looking for is, if you run an outpatient clinic with your consultant, do you, for example, select your patients irrespective of how complex they are, or do you aim to see the simple patients and let your consultant handle the more complex ones? If you were to order investigations, say a CT scan or an ultrasound or an MR, do you order them in excess, or are they within the normal limits of a day-to-day practice? Are you, as a doctor, confident to discharge patients, or do you keep bringing them back, and are you hesitant to discharge? Are you efficient and thorough when seeing new patients? Now, sometimes this might appear rather contradictory because if you do become thorough, it's somewhat difficult to become efficient. So it's quite important to strike a balance between being thorough and at the same time being efficient and keeping the clinic running smoothly. Now, if you do list patients for surgery, are you able to take such decisions? Do you tend to be on the aggressive side in listing for surgery, or are you slightly veering towards a conservative treatment? Now, as long as this is within the normal variability of a consultant practice, this is absolutely acceptable. How good are you at breaking bad news to patients? Are you able to convey details to them in an empathetic manner, explain things to them in a language which they understand, while at the same time covering all aspects of a clinical practice? Dealing with vulnerable adults is a new CIP which has been introduced, particularly with language barriers and ethnically diverse patients. Now, diversity is becoming more and more widespread throughout the UK. It's no longer in the main cities, and it's quite possible that you may end up with patients who do speak a different language to yours and who may not be fluent in English, and how you communicate with them is something that is going to be assessed in a capability in practice in an outpatient section. And probably last but not the least, are the admin staff and the nursing staff happy with your clinic management? This is something that's quite important, and their opinions and management actually count for quite a lot. Now, the CIP on the emergency take, or on how you manage your on-call. Now, it looks at overall how good are you at taking decisions and about patient management. Do you respond promptly to say a trauma call, for example, or do you respond promptly to an emergencies? Are you quite prompt in initiating say, for example, a septic workup? Sometimes missing sepsis and not initiating a septic workup is actually quite a bit of a black mark when you manage your own call. So this is something you really do need to be aware about. Assessments of a patient's morbidities and able to take specialist advice as and when required. A simple example would be neck or femur fracture. Patient presenting with multiple comorbidities, whether you involve orthogeriatrics or whether you involve appropriate medical advice, as the case may be. The basic contention here is, are these decisions appropriate for a day one consultant? Now, no one's expecting you to get it absolutely right all the time, but what the standard to which you will be held is what they expect a junior or a day one consultant to do. The knowledge you sort of present on an emergency take would cover the breadth of the syllabus, in the sense you should be able to manage straightforward, as well as you should be able to recognize unusual cases and take help as appropriate. If on the emergency call you have to take patients to theater, how you communicate with them, the post-op management, particularly your dealings with anesthesia and the recovery staff, are important as well. In all this, in emergencies, how you manage challenging interpersonal situations with staff and relatives is also taken into account. Now, the next one is the capability in practice for the ward round. It's a little more straightforward, but what is essentially looked at is, as a trainee or as a CESR candidate, how do you prepare for a ward round? Do you get a handover from the overnight team? Do you get any information on patients who are unwell? Do you plan the round in such a way that the unwell patients are seen first and not left languishing towards the end of the round? Do you coordinate with the team? Do you, for example, get the ward nurses involved, get the junior doctors involved as part of the rounds, get the SCPs or surgical practitioners or other healthcare assistants involved in the management as well? Again, like in the clinic, what is looked for is a systematic approach to each patient. They want you to be unhurried yet efficient. Communication, particularly with ward patients, does play a very important role. And one thing which really stands out in the CIPs of the ward round is whether you're able to handle a complication from a case which you have personally performed. For example, a post-operative day 2, day 3 wound infection or wound dehiscence or wounds oozage or soakage, how you handle post-operative bleeding, or if there's a suspicion of DVT. Again, we have spoken about how junior doctors are to be involved in ward round, and again, whether you take help from appropriate specialties as required. Now, the CIP of an operating list is something which will be familiar to most surgeons who have actually filled up a procedure-based assessment. It's essentially the same, and it looks at whether you are a methodical surgeon, whether your level of skills when starting a rotation, your attention to detail, intra-op decision making, your capability of operative skills, for example, in a certain subspecialty. For example, if you are more skilled in, say, laparoscopy or arthroscopic procedures vis-a-vis open procedures, that's something that would be taken into consideration. How you construct an operative note, how you select your cases. We have already covered this in the clinic. Whether your informed consent is in line with legislation, remembering both the Bolam and the Montgomery principles. Whether you ensure your patients are prepped and ready, and how you interact with theatre staff and post-operative recovery staff as well. Now, the last CIP for the general surgical curriculum is how you handle a multidisciplinary meeting. Now, this may vary depending on which specialty you are, and you basically need to be aware of the pathways and the administrative processes supporting an MDT. In essence, you should be aware of which are the specialties involved, how an MDT meeting is set up, what are the components of the MDT, etc. What's most important is you should be clinically aware of which cases would require MDT input, and you should have the ability to present such a case in the MDT meeting. What's most important here is you are able to recognize uncertainty and that you are able to manage it as well. So in essence, it looks at how you can work effectively with MDT colleagues and whether you are able to handle a disagreement which may arise as a result of an MDT decision. Now, those are the 5 CIPs, or the capabilities in practice, which are common for all the surgical specialties. Okay, now the CIPs are essentially only for surgical specialties. The medical specialties do not have to do a CIP, and the capabilities in practice have equal weightage to the generic professional responsibilities, which we will come to in a minute. Now, I'm aware that it's a lot of change, and when you look at it initially, you get the feeling that everything is changed. And then when you study it in more detail, you find that, okay, some things are actually making it better. And in other parts, you feel that, all right, the old one was still better. Is that worth changing? You wonder why they keep changing. And at the end of it, I can't tell what's changed really. But essentially, if you look at what we have discussed so far, the CIPs are basically all the things that you do on a day-to-day basis in your working week is now being put into a formal assessment, and that's basically all it is. Now, we go to the generic professional capabilities. Now, what do you mean by GPCs? These give a detailed description of those capabilities which are essential to deliver safe, high quality and effective practice as a doctor in the United Kingdom. This was developed by the GMC. The reason for this was as a result of investigation following a few serious incidents in which it was found that day one consultants were lacking in certain specific areas, and it's as a response to these serious incidents that this was developed by the GMC in association with the Royal Colleges. So basically there are basically three domains, or 9 domains, but the basic 3 are professional values and behaviors, knowledge and skills. Now, there are certain themed domains which are research, education, safeguarding vulnerable groups, patient safety, leadership and team working, health promotion, and illness prevention. So if you look at all what I said in detail, if you look at the circles, the 3 circles are, the core is the professional values and behaviors, surrounded by the circle of professional skills, surrounded by professional knowledge. Now, interspersed in between these are the themed domains, which are the health prevention, leadership, patient safety, safeguarding, education, and research. Now, if you look at it, safeguarding vulnerable groups is something which is relatively new, as well as is health promotion and illness prevention. The rest of it, research, education, patient safety, leadership, are things which were rather well established in the previous curriculum as well. So let's look at what professional values entails. Now, I trust that as a doctor working in the United Kingdom, you would have read through the GMC's Good Medical Practice. Now, this is basically a summary of the good medical practice. I'm not going to go into the details of good medical practice because it's available in the public domain, and it's something for you to just read and reflect on. Now, on to the professional skills. It's basically divided into communication skills, dealing with complexity and uncertainty, and clinical skills. Now, these are the 3 subdivisions of the professional skills. Now, what happens is communication skills and clinical skills are things which you're used to, but the dealing with complexity and uncertainty is the new kid on the block here. Now, it's certainly understood that there will be uncertainties of achieving specific outcomes in clinical practice. Whether you're able to manage the uncertainty of treatment success or failure, some procedures may have a very good track record, but other procedures may not. Whether you're able to take that into your practice. Most of these are again publicly available, but I'm just going to highlight and put in bold some of the things which I felt are important. So if you're able to explain that well-being is a complex physical, mental and social interaction, again, your management strategies and how you adopt them in dealing with extremes of age, in dealing with elderly patients, as well as youngsters, as well as people who are frail, and managing the personal challenges of coping with uncertainty and managing mental health conditions as well. It's also important to know that you should recognize the limits of your own competence and refer patients to colleagues as appropriate. Clinical skills, this is basically self-explanatory. The only things which are sort of new are the humane interventions and the using medical devices safely. Prescribing medicines is something which has always been important, as is history taking, infection control, etc. So professional knowledge now covers professional requirements such as you being registered with the General Medical Council, in that you have the appropriate insurance, the national legislative and the healthcare systems in the four countries, basically Scotland, Wales and Northern Ireland. There are minor differences in the healthcare delivery modes, and depending on which area you are, it's important to be aware of these differences. So basically, if you put all these together, now you have a workplace-based assessments and you have a mandatory workplace-based assessments. So you might be tempted to think that the CIPs and the GPCs are the way forward. So what is going to happen to the routine assessments which you had? So what's going to happen is you will have mandatory assessments for the index procedures, and depending on which surgical specialty you are, your index procedures will be listed in your SSG. Okay, but all the other assessments will become optional. Okay. In addition to these two, you will have a multi-source feedback, which is standard. You will be required, if you are a trainee, to do a self-assessment. You will have to complete your intercollegiate exam. In addition, you will have to complete your multiple consultant report. And all this feeds into your ARCP. Now, as a CESR candidate, at the moment, the self-assessment is probably not mandatory, but in the interest of trying to mimic what a trainee does, it's probably a good idea to do it, and it's a good evidence to show a reflection. So the highlights here are the trainees will be assessed through the MCR, GPCs will carry equal weight to CIPs. The capabilities in practice will indicate the end point of training, which means that if you achieve grade 4 or grade 5, that's when you will be considered equivalent to a day 1 consultant. The learning agreement gets a lot of importance here. This is what was previously used to be just a routine couple of meetings, now gains a lot more importance in light of the CIPs and GPCs. But the role of the workplace-based assessments is being rebalanced. As I said, you will have assessments for the critical conditions, but as far as the routine workplace-based assessments goes, they will become optional. And there will be a transition arrangements for this new curriculum to come in place, and that will depend on which specialty you are. Finally, we come to the MCR, which is the multiple consultant report. So as you can see, it's pretty straightforward. You have a lead consultant and you have a collaborating consultant. You need a minimum of 2 consultants, but it operates on a sort of the more the merrier policy. So the more consultants you get, the better it becomes. So here, if you see, it gives a little warning just at the beginning, which says the utmost integrity and probity is expected of you in completing this form. Inaccurate or misleading completion could result in danger to patient safety. It doesn't get any more stark than that. Now, the MCR for the CIPs this is how it goes. So you manage an outpatient clinic, the emergency on call, the ward round, the operating list. You have levels of supervision, which is 1 to 5. In this, the level 4 is what a day 1 consultant would do, and a level 5 is when you exceed the level of a day one consultant. And I think this is something that would be quite applicable to a CESR candidate, given that some of them would have an enormous number of years of experience. The MCR for the generic professional capabilities goes on to all the little descriptors which we spoke about. They basically have to write comments and deem whether you are appropriate for independent practice in each of these. Now, the end point of training is when you reach a level 4 or a level 5. You must be capable of unsupervised practice in all the GIPs and the GPCs. These are the levels of supervision. As I said, 1, 2, 3 are pretty straightforward, and as before, level 5 is the new one which has been added when you are trusted to act at a level beyond a day one consultant. I know all this is quite a lot. This video will be placed on the CESR UK YouTube channel, in which if you do need to go through this again and again to get a better understanding. Now I'm going to take you through some of the subspecialty changes for each specialty. Now this particular slides are for general surgery, and in this they have developed specific esophagogastric, hepatopancreatobiliary and trauma special interests have been given. General surgery of childhood has been addressed because that's it enables trainees to develop this alongside another special interest. There's a GIT module incorporating general surgery of childhood. Oncoplastic breast has resulted in the breast special interest section being completely rewritten. Currently, you have to rotate now through both upper and lower GI. There has been a rebalancing of the emergency and the elective modules. It was felt that the general surgery curriculum had placed more emphasis on elective modules, and there were complications arising in emergency care, and as a result the emergency care has been given more emphasis in the new curriculum. It's important to have a special interest, but it's also important to complete all modules in elective and emergency surgery, in addition to the new trauma module which has been incorporated as well. Now, with regards to cardiothoracic surgery, as I said earlier, most surgical specialties have only the 5 capabilities in practice. But cardiothoracic has 6 and 7, which is managing patients within a critical care area, and 7 is assessing surgical outcomes both at a personal and a unit level. For pediatric surgery, number 6 is managing an infant in a NICU or a PICU, and plastic surgery number 6 means safely assimilating new technologies and advancing techniques. So the important thing here is to organize your evidence in part 1, 2, 3, 4. So as I said, we have covered part 3 and part 4 in detail in this lecture, but part 1 and part 2 still remain the same. Now when you organize your part 1, it's again divided into what's called sequences. It basically is exactly what you were doing before. Part 2, the sequence is numbered 5 to 13. Part 3, the CIP sequence is 19 to 24, and part 4, the sequence is 25. As I said, there is a lot of jargon in this. There's a lot of new vocabulary which has been introduced. All of this can seem very confusing initially, but a study of this will show that all this is basically quite simple. Most of the curriculum is what you were doing till now, and all the new changes to the curriculum are basically a formal assessment of what you regularly do in a clinical scenario. Now, I'm going to talk a little bit about what all this means for the CESR candidate. Now, bear in mind, the new curriculum is just being introduced, and it will probably take a good couple of years before we can understand its effects. And so the rest of this talk is going to be my interpretation of how this is going to turn out. Now, basically, the power has gone back to the trainers or to the consultants. What they are looking at is a holistic approach. It's not whether you are simply capable of performing a procedure X or procedure Y, or whether you have completed the required numbers, but whether in totality and in balance you are capable of practicing safely as a consultant. Now, one of the common questions a CESR candidate asks is, how often should I get a multiple consultant report? Now, for a CESR candidate, it's at the moment you just need one MCR. This is quite different from trainees. Trainees are expected to get MCRs during the entire duration of a placement. They probably need an MCR at 3 months when they start a placement, and another MCR at 6 months as well. So you can expect that when a trainee completes about 6 to 7 years of rotation, there would be at least about 10 to 20 MCRs in there. However, for CESR, although the observations are over a similar time frame, what is just expected is that it would be just like the final MCR for a trainee. It should just be a summative assessment. It's important to do this within the last 6 months prior to making your CESR application. So this is something you do need to cover. It means that if you plan to submit your CESR application, say in 2 years' time, you should aim for your MCR to be completed within 1.5 to 2 years and at that time period. And however, the MCR is expected to cover the sort of 6-year duration as well. Now, this might create some logistical issues, especially for people who are switching jobs and who are planning to change from one rotation to another. My advice is, if it means that you need to do more than one MCR, then you just get more MCRs as necessary. What the GMC is very clear on is the MCR should be a prospective assessment. They do not like it and they do not expect it to be retrospective. Right. Now, if you look at the JCST guidelines, it says clearly that only one MCR is required. You can keep checking their websites if there are any changes to this. You need minimum of 2 consultants who regularly work with the applicant, and more MCRs may be required if necessary. Now, can the CESR candidate be present at the MCR meeting? Now, there's a very long explanation which has been given in answer to this, but the short answer is no. The reason given is that they expect the MCR to be much more meaningful if the trainee or the CESR candidate is not present, but instead if the trainee does a reflection on the MCR, and then to see if the MCR output and the reflection match up is what was felt to be a better assessment. They thought that the process of arriving at a collective judgment would not be improved by the presence of the candidate there. And so, as I said, you will get your dedicated feedback backwards, but what they expect you to do is not attend the meeting, but give a reflection on what you expect it will be, and then take the feedback from the MCR and try and correlate both. How many consultants to meet up for an MCR? At least 2, but as I said, the more the merrier. And it's every consultant may not have evidence on every aspect of your practice. So some consultants may have assessed you only in 3 out of 5 capabilities in practice, but it's quite possible the other consultant might be able to. So in some ways, it's actually good to have more consultants for your MCR. And in the MCR, it is important for the consultant to indicate which aspect that they are happy with and which aspect that they are not. Does having a good MCR guarantee your success in CESR? Sadly, no. It's only one aspect of it. It has to be covered with the slide which I showed earlier. It has to be still balanced with your workplace, the mandatory assessments for the PBAs and CBDs. It has to go with your MSFs, your intercollegiate exams, and it's only one part of the evidence. But nevertheless, as it's the new kid on the block, understandably there is some concern about it. This is a tricky one. If I don't have good relations with my consultant and can't get an MCR, is there an alternative? Now, theoretically, yes. If you look at Annex A of your specialty specific guidance, whichever specialty you are, it lists in detail what you can do, which is the following. You will need to present evidence, and this evidence will need to be very strong. You will need to map your evidence to the CIP and the GPCs. You should state which item shows equivalence and describe why, and you provide reflection. And it's very important that you provide evidence showing what you have done very clearly. Now, this is sort of the way this has been phrased is it gives the impression that the MCR is the way forwards, and only if you have no other choice and you can't get an MCR, then you go for these descriptors, because it's really much easier having an MCR and showing your evidence, because the alternative is simply too onerous. So you've seen the slide where I said about the huge number of changes in the curriculum, but there are a lot of things which haven't changed. What hasn't changed? Using workplace-based assessments and PBAs and CBDs will continue. It's just that there has been some rebalance on how many you need and how their importance are. The content and the subject of your training has not changed. Your exit exam has not changed. You still need your intercollegiate surgical exam to show your level of experience. The mechanisms for teaching and training has not changed. The processes by which education and experience is delivered is still the same. The end point of training has not changed. So, what are the issues with the new curriculum for the CESR candidate? And again, this is my perspective. There is a lot of trainer buy-in required for this. You really need your consultant's help for CESR much more than before. It also helps if your trainer is familiar with the changes to the curriculum, but this is something that should come in with time. For the CESR candidate, there are a lot more questionables introduced into the system. Now, while CESR candidates have shown themselves to be quite resilient when it comes to filling in the building blocks and achieving competencies, whether it's possible that they adopt the holistic model is something that remains to be seen. I do have a feeling that this will possibly be favorable for locum consultants or people who have been working in a sort of independent responsibility for a while. They may find this a lot easier to do, but again, this remains to be seen. So, as I said, are we reinventing the wheel? Is this something that was there before and that hasn't changed? Only time will tell. But in the meantime, I hope that this has given you some idea of what CIPs and GPCs are and how they will come into your pathway. This lecture will be available, and if you have any questions, you can address them to me on the CESR UK YouTube channel. Thank you very much.